Hola, buenas noches. ¿Cómo están? Les habla Ignacio Miranda, ginecólogo, presidente del capítulo de cirugía mínimamente invasiva. Y es un honor y un placer estar aquí con ustedes para nuevamente en estos webinars que organizamos con el capítulo de cirugía mínimamente invasiva y presentar con el doctor Aníbal Escarela, que, ¿cómo se llama? Y el profesor doctor Miller de Estados Unidos, del AGL, y es presentar este tema tan interesante que, ¿cómo se llama? Que yo creo que a todos nos ha traído problemas en el último tiempo. Así que, Aníbal, ¿cómo estás?
Hola Ignacio, ¿cómo estás? Bueno, feliz de estar acá con todos ustedes, transmitiendo aquí en vivo desde Sochaux con un gran amigo, profesor Charles Miller. Él es norteamericano, es presidente y fundador del Instituto de Cirugía de Ginecología Avanzada, el Instituto de FIP, el Instituto Avanzado de Preservación de la Fertilidad y el Instituto Avanzado de Contornos Corporales de Charles Miller and Associated. Él es profesor de obstetricia y ginecología del Departamento de Ciencias Clínicas de la Universidad de Medicina y Ciencias de Rosalind Franklin, es experto de renombre internacional en cirugía ginecológica mínimamente invasiva, es director de la beca del AGL de cirugía mínimamente invasiva y de endocrinología reproductiva, y además hoy supimos que fue nombrado director honorario del próximo AGL Meeting, que va a ser en Colorado en diciembre, así que esperamos contar con todos ustedes. Y aquí me llegó una sorpresita, así que ya que llegó la ponemos en primera fila.
Hola. Hola.
Profesor Miller.
Hi, professor.
Hola, Anabel, Ignacio. Gracias, gracias. Hola, todos, amigos y amigas. That's as good as the Spanish I know. But we'll be talking in English from here on out.
Thank you, Professor Miller, for being with us in this meeting. Gracias, Profesor Miller, por estar acá con nosotros. It's really a real honor. It's a real honor to have you here in this audience. It's a privilege to have you with us, presenting this important thematic topic about the new management of miscarriage, right?
Thank you. Yes, I hope everyone finds it interesting and considers doing this as part of their practice. And I hope after this lecture, they'll understand why I'm so passionate about this.
Bueno, el profesor Miller dice que está muy contento de estar aquí, que esta clase va a ser muy, muy importante, yo creo que de actualizarnos en todo lo que es el manejo y espera que claramente que lo disfrutemos todos esta clase y por supuesto va a estar en la ronda de preguntas al final. Aníbal, profesor Miller, can we start?
Please.
Thank you.
Thank you.
Vamos entonces.
Gracias.
Gracias. Good morning, everyone. I really appreciate having this opportunity to address the Chilean OBGYN Society. I would love to be with you in Chile. Though we're having a nice sunny day in Chicago after a lunar eclipse last night. But I digress. I want to speak with you today about changing the paradigm for the treatment of first trimester miscarriage, hysteroscopic evacuation, otherwise known as throw away your suction curettage. In this presentation, I will discuss the advantages and disadvantages of a hysteroscopic approach to first trimester loss. I will discuss how to perform a hysteroscopic evacuation and discuss the advantages and disadvantages of expectant management, medical management, and surgical management via suction curettage for the treatment of first trimester miscarriage. We know that unfortunately, 1 in 6 to 1 in 4 of pregnancies will end in miscarriage. And we know that the frequency of clinically recognized pregnancy loss will increase with age. That is to say, By 35, it's 20%. But by 45, nearly all pregnancies end up in miscarriage. We also know that about 50% of all miscarriages are secondary to chromosomal abnormalities. The fact is, I am a reproductive endocrinologist, and I do believe that every loss should be investigated for a chromosomal abnormality. Why? Because if there is a chromosomal abnormality, depending on that abnormality, for example, a translocation, one may wish to then go to proceed to doing testing on the embryos to assure that you're putting back a normal embryo. By the same token, if the genetics come back normal, then you're justified to look at other testing. Look at hormonal testing, for example, potential autoimmune testing, to see if you can cut down the risk of subsequent loss. When we look at success rate for early pregnancy loss, surgical management would appear to be best, with medical management in second place. Now, how do I define success? Well, surgical therapy offers us shorter time to completion and lower risk of unplanned hospitalization. One must remember, however, that there are potential risks related to anesthesia, uterine perforation, cervical trauma, infection, and subsequent intrauterine adhesions, all related to suction curettage. Now, speaking about suction curettage, why do I firmly believe that we must throw away the suction curettage? Well, we know that there's been a recent systematic review demonstrating that DNC for miscarriage is associated with an increased risk of preterm birth. We know that the DNC can negatively impact that endometrial thickness. Again, being an infertility specialist, I can't tell you the number of patients who have subsequent trauma problems with lining thickening, who have had prior DNCs for miscarriage. And we know that that number of DNCs will have an additive effect on damage to the endometrium. We also know that in comparison to a visualization, a hysteroscopic approach to the treatment of retained products of conception, we know that a DNC has much lower success rate in evacuating those RPOCs. And thinking globally, when is the last time in medicine we like to perform a procedure without visualization? That's not what we do. This is an excellent study by Hooker out of the Netherlands. Hans Broman, a great friend of mine, was one of the co-authors on this paper, one of the seniors. They looked at a systematic review and meta-analysis in 2013. It was actually the first published systematic review and meta-analysis looking at intrauterine adhesions post-miscarriage and potential risk factors increasing the concern. They looked at over 900 women in 10 prospective studies, looking at hysteroscopic evaluation within 12 months. And then they looked at 8 other prospective studies, looking at 1,700 plus women, looking at long-term reproductive outcome. What they noted was that intrauterine adhesions are thought to develop secondary to trauma at the basal layer of the endometrium. And this can be due to intrauterine trauma, such as a DNC, subsequent to infection, or caused by retention of trophoblastic disease. We also know that there's a huge spectrum when it comes to intrauterine adhesions, anywhere from asymptomatic concerns all the way up to menstrual-related concerns, from amenorrhea to heavy menstrual bleeding to bleeding between periods, and also dysmenorrhea-related menstrual-related syndrome and pelvic pain. There can be fertility issues related to infertility and increased risk of recurrent miscarriage. And finally, there can be pregnancy-related symptoms, all the way from increased risk of ectopic to problems with abnormal placentation, accretus, percretus, incretus. There can also be concerns with growth restriction and premature delivery. Finally, there's a concern of postpartum hemorrhage. All can occur due to intrauterine adhesions. In the Hooker study, they found that the prevalence of intrauterine adhesions in all patients treated by various modalities varied between 3 and 38%, with a pooled prevalence in nearly 1 in 5 patients had evidence of adhesions post treatment of miscarriage. The most important factor in adhesion formation was women with 2 or 3 or more miscarriages showed an increase that were treated via DNC. Women with 2 or 3 or more miscarriages had an increased risk of intrauterine adhesions. That is to say, recurrent curettage procedures were identified as the most important risk of adhesion formation. So why do I recommend a hysteroscopic approach? First of all, as we've already stated, when you compare a suction curettage to a hysteroscopic treatment of retained products of conception, we know that you're going to have much better evacuation of the tissue and much less risk of adhesion formation. I think it's very easy when we extrapolate from retained products to first trimester loss that we would expect much the same. We also know that there can be increased risk or increased ability to identify chromosomal abnormality when dealing with a hysteroscopic approach. This was actually done in my practice. Arthi Chokeri Singh, when she was with me, looked back at my cases of miscarriage that we had treated over the years with first trimester loss. Group 1 was the standard way we approached our first trimester loss. That is suction curettage, careful examination of the tissue, and trying to separate as best we could the decidua from chorionic villi. In these patients, they may have had a follow-up hysteroscopy at the end of the procedure. Most, however, did not. Group 2 was treated with operative hysteroscopy. We actually first biopsied the chorionic villi and then went to a suction curettage that was just in the specific area that we had removed the products from. We then looked at a second look hysteroscopy to make sure that there were no RPOCs as best as we could visualize. In this group, the first group of the 174 patients undergoing DNC, 159 had fetal chromosome studies, and 159 were looked at for retained products of conception. In the other group, the operative hysteroscopy group, where we first biopsied the chorionic villi, 87 underwent fetal chromosome evaluation, while 80 underwent retained products evaluation. And this is certainly because some of the patients were referred in from another practice. And this is the way that we did this at the time. You can see here the products of conception, failed pregnancy, and now we're using a cold scissors to come around the products. And I would try to biopsy as much of the products as I could, so the very largest specimen I could. But you could see when we're coming in laterally, it was not an easy thing. And sometimes we would get into bleeding and obscure the field. So this was not the easiest of techniques by any means, but you can see the villi here as we go around and cut out this specimen. But once we went ahead and finished this up and detached a portion, it was still a blind procedure because we would have to go in with a polyp forceps in order to remove this tissue. So again, we got a good specimen, and here we now look at the end, and we would put our hysteroscope very close to the endometrium so that we could look for retained products. But again, a portion of this was a blind procedure. But we had very good results. If you look at group 1, we saw a number of abnormal presentations, abnormal chromosomes. However, 36% of our patients could not be evaluated because of maternal contamination or a tissue source was unknown. While in the hysteroscopic group, only 10% we did not get a acknowledgement in terms of the chromosomes. And this was because of maternal contamination, or we could not define the tissue source. So in essence, we proved that operative hysteroscopy for the evacuation of loss gave us better evaluation with really no significant difference in retained products of conception than a pure suction curettage method. So who do we do this hysteroscopic approach to miscarriage, first trimester loss on? At this point, virtually any patient within the first trimester is a candidate for a hysteroscopic evaluation. I can tell you, if you are starting the procedure, I would recommend that you do this on patients 8 weeks gestation or below. I would also tell you that later gestations can be more difficult. So how do we look at this as a step-by-step procedure? Well, let's look at a couple examples. This was one of my early ones. You can see the miscarriage. This is a 30-year-old who had her second miscarriage. There was no fetal pull. You can see the HCG was rather low. And this came back as XX, but there was no maternal contamination. So we went ahead and did a workup and found that she was positive for antiphospholipid antibodies. As all my patients, she had a saline-infused sonogram. You can see I'm using the TrueClear. In this case, from Medtronic. In this case, I use the firm tissue blade because I thought it would make my procedure shorter. Now, this is actually endometrium. I'm pointing this out to you that I don't have to take that, but I do want to take this. And I look at it from this grayish hue. Follow-up saline was negative, and the patient went on to be treated with Lovenox and had a successful pregnancy. Here's yet another case. The field is not as good, and sometimes if the field is not as good, we'll increase our pressure and we'll go ahead and let the fluid run through for a while. Here posteriorly, you see the products. I'm again using the dense tissue blade. You can see the gestational sac being removed in this. You see some villi. And we can really get very good visualization. I've added another component. I do this, I have ultrasound in the room. So I am doing this with ultrasound guidance as well. That has at times led me to being able to have a more complete procedure. Now, this was a patient who had a loss secondary to a chromosomal abnormality and went on to go to PGTA and have a normally tested embryo that was put back and had a successful pregnancy. You can still see the products that need to be removed. We're getting very good visualization here. And our endpoint is to see no villi, no areas of the gestational sac. Here's yet another that was in the corner. This is a PGTA transferred embryo. And still there was miscarriage. And interestingly, we sent it out for study again. And even though we were told the embryo was normal, it turned out to be a trisomy. So here there was a mosaic embryo. And now I'm using the instrument I use now, which is the soft blade. I like to use the mini soft blade from TrueClear. I do most of these in my office. It is less expensive and the tissue is soft, so it works every bit as good as the dense tissue blade. And you can see, I just follow this around. And you'll see me work very efficiently, going from one area to the next to remove this tissue. Again, as stated, now I do most of these in my office. We use Pitocin at times to help, especially in the later, the more advanced first trimester losses, especially when there's a fetal pole. So I'll give intravenous Pitocin. When I'm doing this in the hospital, I may use vasopressin instead. But you can see I'm working very efficiently, visualizing well to remove all the products. And sometimes you have to kind of lift that tissue off as I'm doing here. And we're able to easily remove this. You got it, as you see. Now this is a 9-week gestation. And this is that we had 3 different ultrasounds to show that there was no viability to this fetus. And you can see the yolk sac here. I've been able to identify a single vessel cord in terms of this. I've seen limb problems with this. Again, I waited a week. I put in Pitocin in this case, all to minimize risk. Okay. And you can see that this is a case where there is a 2-vessel cord here, and there was concern about the right leg in this fetus. So as we look at this in a step-by-step summary, I mentioned if pregnancy loss is recent and late in the first trimester, consider waiting 1 week just to have some involution. We do use a fluid management system for this procedure, even in my office. When I'm doing septum, when I'm doing lice of adhesions, polyps, etc., I do not use the system. But for my first trimester losses, I do use a fluid management system. I now use ultrasound guidance. My instrument of choice is the Medtronic Mini Soft Blade. We wrote on this, consider vasopressin. We use more Pitocin now than vasopressin. We evacuate only those miscarriage tissue, the products of conception. If the fluid is blood tinged, take your foot off the pedal and just allow the fluid to circulate with that fluid management system. And have a suction D and C equipment available if indeed visualization is poor. Now, this was an article in JMIG that was in 2021, and this is from an Israeli group who looked at 10 patients prospectively. All of the patients were losses less than 10 weeks from last menstrual period. And they were able to use hysteroscopic evacuation of these patients. Now, interesting, 4 of these went on to be to use suction curettage because they did not feel they removed all the tissue. Indeed, pathology said that they had removed all the tissue. This is in fertility FNS reports, fertility and sterility reports, an online journal, and this is an article that Stacy Young from Stanford and I just reported on hysteroscopic resection of early pregnancy loss, and talks about our management. And this is a study that we're in the process of putting together. We've looked at 74 patients. Nearly 2/3 were performed in my office, with a third being performed in the OR. In my office, I use sedation. In the OR, the anesthesiologists choose to do these under general. Mean gestational age were anywhere from 5 to 11 weeks, on average 8 and 1 day, 8 weeks, 1 day. And you can see that there was considerable difference in HCG levels. As I previously said, 50% of all miscarriages are chromosomal. And indeed, as you see here, nearly 50% of the patients that were analyzed and we got back results, indeed were noted to be abnormal. As opposed to the study that I did with Dr. Chokeri, that 10% yielded no results. With this technique, less than 6% had no results. There were complications. We did have some fluid overload. We talked about that as in excess of 2,500 cc's. And all 3 patients did well on furosemide. They were given Lasix. 1 patient had uterine atony, and 3 patients, because of visualization, had to have DNCs. Postoperatively, there was 1 patient that was treated for an endometritis that responded immediately to antibiotics. Subsequent saline-infused sonogram was totally negative. There were also 3 patients with retained products of conception. 1 patient, I virtually missed the pregnancy. It was a very early pregnancy. The patient demanded that she wanted to get this done early, and truth be known, I missed the site. So it was subsequently removed. There was 1 other patient that had poor visualization, and 1 patient just had retained. We've now imaged 42 of these patients. At the conclusion of this portion of the study, I will look back, and I'm sure many more of these have already undergone imaging. But at this point, I can tell you, of all patients that I have imaged, post-hysteroscopic suction, post-hysteroscopic evacuation of intrauterine miscarriage with TrueClear, there is absolutely no evidence of intrauterine adhesions noted on saline-infused sonogram, ultrasound, or hysteroscopic imaging subsequent to the procedure. And again, my standard for the most part is to use a saline-infused sonogram as my method of observation. And again, no patients on follow-up to this procedure, to hysteroscopic evacuation of first trimester loss, has been noted to have adhesions. So I feel very confident that this is a far better procedure to perform in the event that there is first trimester loss, not only from a standpoint of a very high ability to see chromosomal abnormality in the pregnancy, but also to reduce the risk of both intrauterine adhesions and retained products of conception. Again, I'm very proud to have had the opportunity to discuss my thoughts about first trimester evacuation with hysteroscopic means when there is evidence of miscarriage. And I look forward to seeing you in Chile to be able to lecture on a subject at some other time, hopefully as a follow-up to this. Have a great meeting, and thanks for the invitation. Bye.
Thank you very much, Professor Miller, for your wonderful and awesome presentation. Nice videos.
Thank you.
So, Aníbal, I don't know, any comments, and so we can start the round of questions.
As you are, Professor Miller, I'm a reproductive endocrinologist. I run IVF clinic. So we see every day more and more patients that are coming because of retained products of conception, especially because in Chile it's really popular to do vacuum aspiration and not dilatation and curettage. So there's a national policy to avoid dilatation and curettage, and we're facing more and more patients that are receiving just a vacuum aspiration in office.
So I agree, totally agree with you that when we do any kind of procedures in the operation room, we obviously face two antagonic positions, right? In one side, we want to be gentle enough with the endometrium, and on the other side, we don't want to have retained products. So I think what you have come to is probably the best balance in between both things, right? To avoid damage, but to be sure we're taking enough amount of biopsy to have a genetic analysis, and on the other side, avoid having retention of products.
Right. I do believe that. And obviously the vacuum suction is intermediary and something certain to consider. I just think that in this point, our ability to not have a such a widespread evacuation of tissue, including endometrial tissue, is an advantage. We all know that the endometrium is a pseudo space. And when you have two surfaces that are abraded, there's going to be a much greater risk of subsequent scar tissue. So I just look at general suction still, to me, is not the very, very best, although I agree it's better than using that curette and scraping.
Le comentaba al profesor Miller, para quienes nos están escuchando, en el fondo, que cuando uno hace un legrado uterino o un vaciamiento uterino, uno se enfrenta a dos posiciones antagónicas. Por un lado, dejar la cavidad lo suficientemente sana, pero por otro lado, no dañar el endometrio, que sabemos que es una estructura noble y que es irreemplazable cuando se daña. Entonces, el profesor Miller nos decía en el fondo que esta estrategia que él había elegido permitía balancear las dos de perfecta manera, evitando el daño de la pared anterior y posterior del útero, que cuando quedan contiguas en el daño pueden generar una sinequia y posteriormente un problema reproductivo futuro para ese paciente.
Perfect.
And that is, if you see me when I'm dealing with that tissue, I'm staying above the endometrium. I'm staying above the lining. So I'm just trying to pull that tissue off, as opposed to what we do with polyps or with fibroids with evacuation techniques, is when you put it right on the tissue. So I'm actually using the suction to bring up this soft tissue, again, minimizing that risk to the endometrium. For sure.
Claro, el profesor Miller nos decía en el fondo que lo que él hace es que en vez de apoyarse sobre el tejido y generar un potencial daño sobre el endometrio, lo que él hace es levantar un poquitito la cureta y bajo visión directa permite arrastrar el tejido trofoblástico sin dañar el endometrio subyacente.
So I want to ask another question, Professor Miller. You told us about the 2/3 of your patients were in the outpatient, in not OR, and 1/3 were in OR. So can you make or show us another time which are your criteria to go to the OR and which were to do in the outpatient? I will translate.
Yeah, that's an interesting question. The reason is because of their insurance. So insurance may dictate that I have to take someone to the operating room. Most of these I am doing most of these I'm doing in the clinic, especially when you look at it. Most of the early ones were done in the hospital. So I don't look at it from a standpoint of size, although there's been a couple instances when I'm really late in the first trimester, and just from a standpoint of backup, I say, boy, we better wait and do this in the operating room. I want to again make sure that everybody knows, when I deal with that late first trimester loss, I do wait a little bit. And I know that sometimes can be very difficult for a patient, but by waiting a week, we see involution, and there is less active bleeding at the time of the procedure. So I think that's an added safety benefit to go ahead and wait a little while once the diagnosis has been made.
Entonces, lo que le decía el profesor Miller era un poco de cómo separar, porque tenía 2/3 de los pacientes lo hacía en la consulta, solamente con sedación o incluso sin sedación, y 1/3 lo hacía en sala quirúrgica, y él nos decía que fundamentalmente era en base, ¿cómo se llama?, al seguro que tenía el paciente. Pero claramente, y ahí viene una segunda parte de la pregunta que yo le voy a preguntar al doctor Miller, es: hoy en día tenemos muchos, ¿cómo se llama?, diagnósticos de vascularización de este tejido que se ha implantado, o sea, que se ha mantenido ese aborto retenido con vascularización aumentada. Entonces, ¿qué hacen en esos contextos? ¿Cuál es su conducta? Y probablemente si eso lo hacen en la sala operatoria. Professor Miller, the second question is united with the first one. It's about what do you do with this retained tissue that it's normal nowadays we see a lot, or here in Chile, I think that it's in all the world, is with the ultrasonography that we see the vascularization that is augmented. It's vascularized tissue. So this sometimes make that you can have a lot of bleeding, but many are false positive
Right.
of this vascularization, so
Right.
of this bleeding risk. So how do you deal with these cases?
Well, one thing, I don't overlook it. I take it very seriously. And you are right. Oftentimes there's no difference at all. And it's a very straightforward case. But here is a case that I will likely do in an OR operating room situation. I will give that patient either vasopressin, most likely vasopressin. I do that transcervically to cause that the vasoconstriction, and I do have the potential of suction with me if I have to deal with some real bleeding. So I take that into account. Now it's interesting. Oftentimes, a couple of things about bleeding. Oftentimes after the procedure, I see some type of oozing coming out of the cervix. And so all I will do is to do a fundal massage, just like you would do on a gravid patient doing obstetrics. And I just keep massaging the uterus, and that bleeding, assuredly will stop. Another issue that you have to tell your patient, because we are only removing the products, as the HCG goes down, oftentimes she sees increased bleeding. So I just had one recently. A patient called me up and said, I'm having bleeding and it's pretty brisk. And I explained to her, as I explained to her even when we did the procedure, but again, reaffirmed that this was likely normal. And I said, let me know how it goes over the next couple hours. And generally, it just will stop on its own. We have yet to ever have to go back on someone because of increased bleeding after the miscarriage, as the endometrium is going down, is being passed. The decidua is being passed. But that is something you must be aware of to talk to your patients.
Perfecto. Lo que decía el profesor era que claramente estos casos que hay vascularización aumentada, él los ve, como se llama, principalmente en el quirófano, en el pabellón. La mayoría, tal como muchas veces tengo la experiencia, son falsos positivos de que haya un sangrado importante. Él trata de usa muchas veces vasopresina, lo inyecta probablemente con un ¿cómo se llama? A través del canal de trabajo de los histeroscopios ambulatorios, y de esa forma al vaso contraer el sangrado es menor. También hace masaje, ¿cómo se llama? Y ¿cómo se llama? Trata de que de vuelta harto el fluido para tratar de limpiar. Pero muchas veces, ¿cómo se llama? Ese sangrado es autolimitado y muchas veces pasa. Por lo menos él dice no tiene casos muy que hayan requerido como volver al quirófano después de hacer el procedimiento. No sé si Aníbal quiere hacer otra
And Professor
pregunta.
Miller, you're using a 5mm scope?
Yes, it's a,
hysteroscope?
well, it is actually we dilate up to 7. So we dilate, it's the True Clear. It's actually the mini elite hysteroscope from Medtronics, but we dilate up to between a 6 and 7. Oftentimes, one other thing, we in our surgery, we utilize Cytotec to soften up the uterus, but the cervix rather, we do not use our Cytotec when dealing with miscarriage, because we want that cervix to be firm, so we don't want to have fluid leaking out. We want to have a good ability to see that products.
Okay, so there's a question from the audience that it's related to this comment. If you use or not prostaglandins like misoprostol previous to the procedure?
No, we do not. We do with other for septum, for adhesions, for polyps, for fibroids, but we do not for products for miscarriage, because the cervix is already soft and it dilates up very, very easily.
Perfect. There's another question from Professor Garcia Huidobro. He says, at St. Luke in Brussels, they use the resectoscope to remove the products of conception with the loop, without electricity.
Yes, I'm well aware of that technique. And there's some very, very good people doing that. And I've seen multiple videos on that treatment over the years. The problem is it's harder to evacuate the products. You use that loop and you catch it in the loop, but it's just not as easy to get the products as a continuous suction that we are doing with the True Clear. Obviously, it's a less expensive system, and I realize that, and that has to be balanced. But I don't think you're going to get as good recognition of tissue as you do in this type of situation, where we're really able to capture all the tissue that we're removing.
Perfect. Another question from the audience. Do you have any experience in using your vacuum system in C-section scarred pregnancy?
No, I've done one. I've done one like that hysteroscopically. My way of doing this hysteroscopically is basically the standard way. I just did one on Tuesday, and we go in and we will shave off the caudal surface, the anterior caudal surface, where the isthmocele is. Then we desiccate at the myometrium that's above the defect, the highest part on the defect. Some people recommend excising the cephalid portion as well. I do that simply because a lot of times the isthmocele tissue is inflamed. So some people would just say, I do the caudal surface and desiccate the top. I also will resect the cephalid surface of the niche as well. But I use a resectoscope.
Ok. Ignacio, ¿alguna otra pregunta?
Sí, quería preguntarle acerca de cómo se llama de nuevamente los restos vascularizados, si es que ocupa algún dato de la ecografía con respecto a desde el punto de la velocidad o algún IP de la vascularización, como para un riesgo desde el punto de vista de sangrado. Y lo segundo, si es que él hablaba de la involución que claramente yo también lo ocupo, que es esperar, claramente que al al esperar empieza a secarse un poco este tejido y eso ayuda. Entonces, ¿cuánto uno espera? Eso siempre uno está en la duda porque en esa espera puede empezar a sangrar, entonces siempre ahí está un poco el balance. So, Professor Miller, I wanted to ask two questions. It's about again about the vascularization of this tissue. If you first you told us about waiting a little bit or waiting, I don't know how many days, how many weeks do you wait when you have a strong vascularization of this product of the conception, and if you in the ultrasound you use some, I don't know, a speed or IP of the Doppler to take to feel if it's have a risk of bleeding.
Yes. So yes, the diagnosis is made with Doppler with ultrasound, transvaginal ultrasound. You're very, very correct. And we have found by waiting a week, we have done very, very well. But again, those cases when I feel there's going to be a risk, I will do everything I can to mitigate risk. So that is, I will use vasopressin. I will do it in a hospital situation. I will wait, give it the time. I will do it under ultrasound guidance. So I'm trying to get in and out as quickly as possible. And quite honestly, I've not had a problem. I had one person where we started out. This was a more recent case. This lady has had multiple hysteroscopic lysis of adhesions. And after years and years, and she started amenorrheic when we first saw her. And finally she was pregnant and lost her pregnancy at nearly 10 weeks. And I had a real, that was, we didn't anticipate the bleeding that she had. And that was really a difficult situation. I finally was able to do it with suction. We ended up putting in a balloon, and it turns out that she had myometrium within mixed with the product. So she had an accreta.
Okay.
And that is tough. That was tough, but it was tough with suction. It was tough with everything.
Perfecto. Entonces el profesor habla que lo importante es el doble para hacer el diagnóstico, pero claramente no hay como datos exactos para tratar de hacer un riesgo de estas pacientes. Y segundo, claramente esperar por lo menos, refiere entre 1 a 2 semanas de hecho el diagnóstico. Y en general, refiere que con vasopresina y con el masaje en general no ha tenido muchos problemas, salvo un caso que contó al final, de cual tenía implantado, que se implantaba incluso hasta el miometro, entonces en ese contexto sangró bastante. Thank you very much, Professor Miller. I don't know anyone.
No.
If you have any other questions.
We have tortured enough Professor Miller, so
I would say come to the AHL. Everyone, come to Denver. It'll be a great meeting of education and AHL collegiality. And I look forward. I got that invitation to Chile, guys. So I'll see you in person.
No,
we surely see you
Great.
in AHL and back here in Chile. So the
All
Pisco
right.
Sours are on my way.
All right, Pisco Sour forever. Thank you, guys.
Thank you very much, Professor
All right.
Miller.
You be well. Be well.
Bye,
Take
Professor.
care. Thank you,
Bye-bye.
everyone. Thank you. Ciao.
Chao, hasta luego.